بسم الله الرحمن الرحيم. ميرسي لحضرتك يا دكتور عزة ولكل الأساتذة الأفاضل ودكتور حنان طبعا لدعوتي الكريمة للمؤتمر. My talk is about the thrombotic storm, a rheumatological perspective. هي النقطة بس إن إحنا ما فيش فرق في المانجمنت، إن إحنا مش بتبقى univision، لا بتبقى multidisciplinary team. بس أنا لما هقول النهاردة للثرومبوتيك ستورم هتبقى from my perspective as a pediatric rheumatologist. I have none to disclose, and the agenda of my talk will include definition and causes of thrombotic storm, classification criteria, and clinical presentation of CAPS. We'll know very briefly what is meant by CAPS and management of CAPS. So I will start with the term thrombotic storm. It is first proposed in 1998 by Kitchens, which refers to a pattern of serial acute to subacute thrombotic event that escalated over a very rapid period, ranging from few days just to few weeks, involving progressive thrombosis at multiple sites and preferentially unusual sites like hepatic vein, portal vein, irrespective of the hypercoagulable and thrombophilic markers, because it has a variety of causes. So on the top of the list, as a rheumatological perspective, I placed catastrophic antiphospholipid antibody syndrome and a typical presentation of thrombotic thrombocytopenic purpura, heparin-induced thrombocytopenia and thrombosis, Trousseau syndrome, which can insert associated thrombosis, disseminated intravascular coagulation, and pregnancy complication, which is HELP, hemolysis, elevated liver enzymes with low platelets, idiopathic catastrophic thrombosis, which present with thrombotic storm, but you cannot put your hand on the underlying cause. So why it is termed thrombotic storm? Because regardless the cause, it is marked by multiple organ thrombosis and related dysfunction, and the systemic inflammatory response syndrome, which is attributed to the excessive cytokine release from the affected organs and the tissue damage. So it poses thrombosis and inflammatory hypercytokainemia. So I will, the scope of my talk today is about the catastrophic antiphospholipid syndrome. It is first described by Ronald Ascherson in 1992, and it is rare, representing nearly less than 1% of patients suffered of antiphospholipid antibody syndrome, and characterized by widespread thromboembolic disease with multi-organ failure and high mortality rate. Until now, it is still unclear why some patients with antiphospholipid antibody syndrome develop just recurrent large vessel thrombosis at different intervals and under certain precipitating factors, the classic antiphospholipid syndrome variant, while others develop the thrombotic storm, the catastrophic variant. What about the pathogenesis? Let's start that there must be pathogenic types of antiphospholipid antibodies, because not all antiphospholipid antibodies are pathogenic. So they must be at first pathogenic. And there is two hit theory, which include first, a genetic susceptibility in presence of antiphospholipid antibodies. This is the first hit. And the second hit is either infections that we will see in the next slide, inshallah, that posed together leads to rapid progression of the phenotype of the disease into a catastrophic variant. The pathogenic antiphospholipid antibodies, which confer high risk of thrombotic disease, include lupus anticoagulant, the highest risk, and very high titer of antiphospholipid antibodies, the immunoglobulin G isotype rather than immunoglobulin M or immunoglobulin A. The precipitating factors include infection on the top of the list, either viral or bacterial, representing 60% of cases of pediatric catastrophic antiphospholipid antibody syndrome, malignancy, heterozygous deficiency of a natural anticoagulant, or heterozygous risk of prothrombotic variant, surgery, even minor like dental extraction, withdrawal of or subtherapeutic anticoagulation, minor trauma, flare of an underlying autoimmune disease like SLE, and that cause is not evident in pediatric, which is obstetric complications. So starting with the pathogenic antiphospholipid antibodies through the two-hit theory, they will start as a pro-thrombotic effect by starting to induce excessive platelet aggregation with thromboxane release and decreased platelet adhesion in the first endothelial activation with increased expression of the tissue factor and secretion, which will start extrinsic thrombosis pathway, increased von Willebrand factor expression, increased expression of adhesion molecules, vascular injury and vasoconstriction, excessive activation of the monocyte and neutrophils with subsequent increased tissue factor expression, promotes thrombus formation because of inducing acquired inhibition of activated protein C and or protein S, as well as annexin 5, antifibrinolytic effects through inhibition of plasminogen and plasmin. And at the same time, they will have pro-inflammatory effects through excessive stimulation of secretion of inflammatory cytokines from the monocytes, like tumor necrosis factor alpha, interleukin 1, interleukin 6, and 8, although they are not specifically measured in patients with catastrophic antiphospholipid antibody syndrome owing to the very catastrophic presentation. Complement activation, specifically for complement 5 component, which induce neutrophil activation and recruitment into the tissue, causing local inflammation with the endothelial activation as well, produce excess interleukin 6. And reactive oxygen species, which induce more vascular injury and vasoconstriction. All they pass the two effects, whether pro-thrombotic or pro-inflammatory, they will work together in a vicious circle ending in catastrophic variant of antiphospholipid antibody syndrome. The preliminary classification proposed by Asherson and colleagues for catastrophic antiphospholipid antibody syndrome in 2002, starting evidence of involvement of 3 or more organs, system, and or tissues, development of manifestations simultaneously or serially in a very short duration, usually less than a week, confirmation by histopathology of a small vascular disease, and it is very important to be non-inflammatory, not secondary to vasculitis. Laboratory confirmation of the presence of antiphospholipid antibodies, so we term it definite if it is all the 4 criteria, and probable if any of which are not evident, like 2 organs instead of 3, or absence of laboratory confirmation because of patient death, or absence of histopathology. Same like it takes more than 1 week, but definitely should be less than 1 month. CAPS registry was formed in 2000 to collect data about the presentation, investigation, management of this very rare disorder. So we found that 10% of patients were younger than 18 years of age. The youngest was at the age of 1 month. 87% has initial presentation of CAPS without any history of thrombosis or underlying disease. However, infection was very much evident as a precipitating factors. 69% of these pediatric CAPS patients has primary antiphospholipid antibody syndrome, whereas 31 had underlying childhood onset SLE or lupus-like disease. Precipitating factor, as I said, was mainly infection. Small vessel disease dominates in CAPS. However, large vessel occlusion may also occur and is very common, and that's characterized the CAPS from other causes of thrombotic storm. It commonly involves in the order of frequency: kidney, lung, heart, peripheral vascular system, brain, liver, skin, and GIT. Kidney can present as renal impairment in terms of hypertension, lower limb edema, oliguria, and eventually renal failure. Pulmonary involvement commonly as pulmonary embolism, and in severe cases, acute respiratory distress syndrome, and in minority, pulmonary edema or pulmonary hemorrhage. Cardiac involvement include valvular disease, typically mitral aortic, intracardiac thrombosis intracardiac thrombus, as we see with the index case described beautifully by Dr. Nihad, or myocardial infarction. And I would like to thank Dr. Marwa Wahid because she is the one who did the echo. CNS disease include acute ischemic encephalopathy, strokes, confusion, seizures, and skin involvement. It can be livido reticularis, like the lacy appearance of the skin. or larger reticulation, what's called lividoracemose. And visceral organ involvement can present as acute abdomen, like this case, as well as less other common involvement, like ovarian infarction, bone marrow infarction, esophageal rupture even, and hemorrhage, gastric and colonic ulceration. In laboratory evaluations, thrombocytopenia occur in 70% of patients, but usually is not severe. Microangiopathic hemolytic anemia and schistocyte may be present, but schistocytes are usually very few. Elevated acute phase reactant, we said our storm with hyperinflammatory cytokinemia, complete metabolic panel to evaluate the organ affection. Antiphospholipid antibody testing, which will reveal lupus anticoagulant assay, anticardiolipin immunoglobulin G and or M, and anti-beta-2 glycoprotein 1, mostly of the men 1, same serotypes, immunoglobulin G mainly and M, and all will be in a very high titer. They are not necessarily to be the 3 variants of the pathogenic antiphospholipid antibodies. It's enough just only one. Additional testing for possible differential diagnosis, I have mentioned in the causes of thrombotic storm, ADAM13 activity for thrombotic thrombocytopenic purpura, antiplatelet factor 4, heparin antibodies for the heparin-induced thrombocytopenia, and serum complement 3 and 4 level, although consumed, as we can see in this patient, but we did not complete the immunological pattern. However, isolated deficiency of complement 3 and 4 in these patients are not characterizing anything, because they might be deficient in patients with predominant microangiopathic pattern. And testing for possible treating factor, and never to forget about the thrombophilia workup with communication with our hematological colleagues, and imaging studies typed by the presentation of the patient, CT angiography like in this patient, Doppler studies. Concerning biopsy, it's not at all recommended except in selected cases, and with the calculation of the high-risk sequelae. So the item of histopathological confirmation of non-inflammatory small vessel disease occlusion, it's actually in the acute setting of the disease is never applicable. Coming to the differential diagnosis, I chose the most common causes with the CAPS, TTB, and DIC, and I can facing as a pediatric rheumatologist, complicating our patients. In CAPS, they have different precipitating factors like underlying SLE, or as we can see that it could be the initial presentation with the infection is the most common, or even minor trauma. And never to forget that there is genetic susceptibility, TTB infection, malignancy, DIC infection, and malignancy as well. What's very characteristic for CAPS is large and small vessels involvement, like the index case that has been described by Dr. Nihad. The microangiopathic hemolytic anemia and schistocytes are very few, if any, in CAPS, but they are very prominent in TTB and very few as well in DIC. The BTT is very characteristically prolonged in CAPS if the pathogenic antiphospholipid antibody is lupus anticoagulant, but in TTB it's normal, and in DIC, post-PT, INR, PTT are prolonged because of consumption coagulopathy. Fibrinogen as acute phase reactant, it is normal or high in CAPS and TTB, however, it is low normal or low in DIC. Immunological lab, as we can see, antiphospholipid antibody characteristically high titer in CAPS, while in TTB we'll find ADAM13 deficiency, less than 10% of normal. And this is very important to characterize the primary TTB, because patients with antiphospholipid antibody syndrome might have mild acquired deficiency of ADAM13, and DIC there is none. So going to the principles of treatment in CAPS, patients with suspected CAPS or other thrombotic storm should be treated in a center with appropriate clinical expertise and therapeutic modalities. Multidisciplinary care is often necessary and should be conducted, and may include the involvement of rheumatology, hematology, nephrology, intensive care team, and infectious disease. In addition to general supportive measures, CAPS is typically treated with combination of anticoagulation, high-dose glucocorticoid, and therapeutic plasma exchange, or intravenous immunoglobulin. This is what's termed triple therapy, giving a survival rate of 70 to 78%. And unfortunately, the index patient did not have the time to receive this treatment altogether. Refractory cases are recommended to have add-on therapy must with rituximab or eculizumab, which is a monoclonal antibody against C5a complement component. And that choice between the two drugs depends on the patient condition. If there is more hematological with less kidney severe, so it goes for rituximab. And if it is more renal involvement, it goes for eculizumab. Cyclophosphamide is usually used in CAPS complicating SLE. It is very important to mention that this patient but her general condition was very bad. But her limb, the ischemic limb, and she has dry gangrene. They conducted surgery only in patients with devastating peripheral vascular disease because this gangrenous limb will act as the igniting factor of the storm that will lead to more and more a vicious circle of excessive prothrombotic effect and hyperinflammatory cytokainemia. So coming to this algorithm, we start that CAPS which are very likely or likely. Why it is very likely or likely? Because you can see at presentation, we don't have a laboratory confirmation of pathogenic antiphospholipid antibodies that we should stay at least 12 weeks to be repeated and confirm that it is positive, and will not go to do a biopsy for the patient. But large and small vessel occlusion in a critically ill patient in less than 1 week should put catastrophic antiphospholipid antibody syndrome on the top of the list with evidence of hypercytokainemia and increased acute phase reactant. So if the patient doesn't have bleeding, we'll start anticoagulation. If it does have bleeding, like in this patient, anticoagulation should be withheld. And the choice of anticoagulation is fractionated, is heparin or pattern low molecular weight heparin. And after it will continue for 7 to 10 days. After stabilization of the patient, it can be shifted to warfarin. And it is very important to stress on heparin should never be stopped except after INR turn it to be between 2 to 3. Not by the start of warfarin. Concerning the direct oral anticoagulant is not at all preferred in antiphospholipid antibody syndrome and the CAPS, especially with arterial involvement because of high risk of recurrence of arterial thrombosis and spread. The mechanism underlying is still not clear. And when we start glucocorticoids, it's usually given in high dose like this patient, solimedrol. Like 400, our doses is usually 30 milligram per kg, maximum 1 gram over 3 to 5 days. And then if the patient's general condition improving, it will be shifted to oral steroids at high dose as well, 1 to 2 milligram per kg. And after discharge of the patient, if he's succeeded to make it and be discharged, it will be gradually tapering to reach like low dose half milligram per kg for 2 to 3 months. And it's very important to avoid rapid or sudden withdrawal of steroids because it will have devastating sequelae and increased risk of recurrence. And plasma exchange is the second option, and it is very important if there is predominant microangiopathic manifestation, and IVIG could be used after the session of a plasma exchange. If the patient is refractory, as I said, it will just be rituximab or eculizumab. Eculizumab, the problem, it is not evident and it is very, very expensive. Patients should be followed up, should be strictly followed up, and make sure that the patient is adequately anticoagulated. My last slide is about the relapsing CAPS. It is not common, and it is defined as clinical relapsing of clinical and hematological features of predominantly microangiopathy, recurring after 30 days of apparent remission, And the risk factor for recurrence of CAPS is positive anti-nuclear antibody titer, lupus anticoagulant, and persistently positive even after starting the steroids, underlying systemic lupus, older age of patients, and period of anticoagulants. I would like, at the end of my lecture, to thank you all for your attention and to thank my pediatric allergy, immunology, and rheumatology team. We have lost النهارده دكتور محمد هشام الله يرحمه. I hope ان كلكم تدعوا له ربنا يرحمه يا رب ويحسن اليه وربنا يعني يرحم كل اللي سبقونا ويبارك في اللي موجودين يا رب. ومؤتمرنا ان شاء الله الجاي بقى هيبقى يوم 25 26 اكتوبر باذن الله. It is accredited by the American Association of Continuing Medical Education to include distinguished national and international speakers, and thank you for your attention.